Hello and good afternoon. My name is Stephen Down. I'm an independent best interest assessor, MCA lead for an acute trust, former AMP, and type 1 diabetic myself. I've been asked today to have a discussion in response to a triple SAR in the borough, and particularly focusing on issues around mental capacity for one gentleman who had diabetes. This was a gentleman called Michael, who was 70, had multiple health conditions, including diabetes and leukemia. He lived in a very cluttered and unhygienic home with support from his two daughters, both of whom were said to have an element of learning disability. He was frequently admitted to hospital in a crisis, but often discharged himself against medical advice. Professionals tended to assume that he had capacity to make those decisions, but there were no clearly recorded assessments. His doctor repeatedly said that he couldn't manage his insulin, and yet Michael died after one episode shortly after he'd self-discharged. So we've drawn a panel together today to discuss not just Michael, but other cases as well, and how we might do things differently if we were to do it again. So I'm going to hand you over now to Jodie.
Hi, good afternoon, everyone. I'm Dr. Jyoti Balani. I'm the consultant in diabetes for Sutton Health and Care and Epsom and St. Helier NHS Trust. And I actually am in this meeting especially to talk about safeguarding in relation to diabetes, because one of the examples in today's case was Michael, which has just been told to you. So I'll be talking about mainly safeguarding in the context of diabetes. Thank you.
Thank you, Jyoti. Who's next? Jane, do you want to go next?
Good afternoon. My name's Jane Lovell. I'm a diabetes specialist nurse and I work alongside Jyoti at Sutton Health and Care. And again, I'm here to discuss the issues around safeguarding in diabetes.
Thanks, Jane. Sarah, would you mind coming in at that point?
Of course. My name's Sarah. I'm a social worker and approved mental health professional. I've been employed by the London Borough of Sutton for well over a decade now, and I worked with a client very similar in presentation to Michael.
Thank you, Sarah. And last but not least, Trish.
Hi, good afternoon. My name is Trish Thompson. I am a district nurse by background, and my role now is I manage the community nursing teams within Sutton Health and Care. And I'm here today to talk about how social care and community health could work better together.
Thank you. And can we all say a special thanks to Paris for helping us with the recording and the clever IT bits. Yes. Dr. Balani, can I ask you just to tell us a little bit about how diabetes, particularly hypoglycemia and hypoglycemia, can affect capacity and any sort of related conditions that can also be linked with diabetes and mental capacity?
Yeah. So first of all, diabetes and safeguarding are very closely linked. And this is because the management of diabetes is very complex, especially in vulnerable patients with dementia, patients with learning disabilities. So there is many aspects of diabetes management. First of all, the lifestyle, taking care of the diet each day, every day, 3 times a day, eating, knowing what to eat, what not to eat, the lifestyle. So a good amount of exercise every day. Then the oral medications, taking the medication. Some medications are before the meal, some medications are after the meal. So timing the medication to your meals. And then if they are on injectables, the insulins, that would be the most difficult part, managing the insulins, because sometimes they're once a day, sometimes you have to take it each time you eat your food. So there are 3 or 4 injections in a day. And sometimes you have to even alter the dose of the insulin which you take. And this decision has to be taken by the patient at times, depending upon what their glucose is, what they're eating, whether they have any infection going on. So many things which are even very difficult and very complex, even for a person with very good cognition. So when there is a cognitive disability or cognitive dysfunction, at that time, it becomes extremely difficult to manage all these different arms of diabetes management. One more thing is the blood glucose monitoring. Now, the blood glucose monitoring itself is again a big issue because, I mean, you have to remember to do it before you eat. You have to remember to do it before you check your insulin. You have to remember to do it after you check to see that things are okay. So it's a very complex management. And I find people with normal cognition struggling with diabetes. So it is a real major issue for people with learning disabilities and with vulnerable adults. And we need to support these patients. So, and there is another aspect about diabetes, which we have to remember, that there are chances of having emergencies in diabetes, which could be one, hyperglycemia, which is high glucose, and another one, hypoglycemia, which is low glucose. So the patient has to be ready to understand that his glucose, he should be able to understand his glucose is high and what he should be doing when the glucose is high. Because this at the time when the patient has a high glucose, the patient's mentation or cognitive function could not be normal. So if it is one of these episodes when the patient is refusing insulin, you have to check whether the glucose is high or the glucose is low, and is his mentation not good enough to take the decision. So at that point of time, for that decision, whether he's refusing the insulin, does he have the mental capacity? So the mental capacity could be a problem because of learning disabilities, because of dementia, which is a long term, or it could be because of short term problems like a hyperglycemia episode or a hypoglycemia episode, or the patient is in severe pain, or the patient has an illness or infection which is causing a high grade fever. All these things can actually impair their cognition, and therefore it's really important that the mental capacity not be assessed at one point of time, but consider assessing it at another point of time in a different maybe place with his family members, with in a different situation, because that is possible that the mental, I mean, it could be fluctuating, the mental capacity. That is an important thing to remember. Now,
Before
in
we
this,
move on to that, Dr. Balani, can I just check? So are we saying that if someone's blood sugars are consistently high or consistently low, that can affect their judgment? Is that a fair?
It can affect their judgment.
And does
Yes.
it all? Is there any links between diabetes and other mental conditions, for example?
Yes. So
dementia,
yeah.
mental
So
health
one thing is the metabolic one, which I told you, the high glucose or the low glucose. The other thing is there is also, we commonly see anxiety and depression and other mental health conditions in patients with diabetes. Now, episodes of severe depression and mental health conditions can also affect their cognitive or their ability to take the decisions correctly. So that is another thing we have to consider. And what I would also say is that there's also executive functioning, which you need to think. That means the patient could be understanding that he should be taking his insulin. He understands the importance why he should take the insulin, and if he doesn't take, what happens. But he probably is not able to do it properly. So there are many different insulin pens which the patients cannot inject because of dexterity problems in their fingers. Sometimes they cannot read the glucose readings because of visual problems. So there are, even the executive functioning can be a problem. So they know that they should be taking it, but they are not good at taking it, or they cannot take it, and that's why they are not being able to do it. So these are the multiple things we have to consider in patients of diabetes. And I think one good thing we have to remember is management of diabetes is 24/7, 365 days of the year. So I think diabetes and safeguarding are linked because they tend to self-neglect. So the vulnerable adults tend to neglect, whether it is taking the insulin, whether it is glucose monitoring. And I think the healthcare professional needs to be really aware that these are the possibilities, especially when they are in, like, for example, if they are with depression or they are having any infection, the glucose can go very high up, and that can also make them forget to take their insulin, or they have something else in their mind which is going on. They're worried about something else and they may not take their insulin. So there are several things, because this is an ongoing long process. There's very much likelihood that they may have self-neglect.
What I would like to do now is we consulted some of the practitioners in Sutton who had worked in similar teams to those teams who were supporting Michael to get their view on what learning could we pull from this Safeguarding Adults review. I know some common themes came from that, and I would just like to go through some of those with some other guests. So if I can start with one of the things I think that was commonly raised was, people asked questioning what was the role for social care in what they saw was a healthcare condition. Sarath, as someone who works with a very similar case at the moment, what do you think are the advantages and strengths of bringing social care into the management of diabetes and supporting people with diabetes? Where are the overlaps?
I think an essential part of diabetes management is one of the core parts of the Care Act assessment, which is managing and maintaining nutrition. That certainly formed the basis of my approach with the client that I've been working alongside, who's quite similar to Michael in presentation. I think that aspect has an impact on all spheres of health interactions a client patient may have with services. And I think certainly there's a lot of scope for collaborative approaches to individuals such as Michael, who are declining services, but who still have a risk that needs to be managed. And I think exactly as Dr. Blani has made reference to, there's positive outcomes to be had when you approach an individual from this perspective, rather than this notion of sticking to your lane, if I could put it that way.
Yeah.
Because ultimately there's a vulnerable adult at the center of all of these discussions, and I think that can't be understated.
And I think it's acknowledging that, it may be a health condition, but the management of a day-to-day basis certainly impacts on his social living skills as well, and the care and support he's going to need. We hear that he lived in a very unhygienic environment, that he may not have had the support he needed. His daughters had needs of their own, for example. So I think, you're absolutely correct to refer back to the Care Act in the sense that there is a legal duty to consider wider needs, a holistic approach, isn't there? Assessment in that sense. Can I come back to you, Dr. Balani, just to talk around decision making? Because one of the things that's common is that people tend to refer the responsibility for making the decision up overs. And as a consultant, often the last point of call for people to say, does this person have capacity? What do you think are, in a situation like Michael's, where there's multi decisions and lots of professionals involved, how would you differentiate who the decision maker would be for different decisions?
I would say that an MDT would be a must in such a person like Michael. And I think the decision would have to be taken in an MDT. It should not be an individual professional's decision, because all the information should be shared between all the agencies, the carers and the family, the GP, everybody concerned. And the past history should have been taken. I mean, with Michael especially, that 2 or 3 times he's got admitted with diabetic ketoacidosis, that should have been taken into consideration. Because see, when the person is with diabetic ketoacidosis, he's not in a condition to take a decision at that point of time because of the high ketones in the body, which make the cognitive function a problem. So
there's also something around being mindful of what the decision is, isn't there?
Yes,
in a sense.
Exactly.
So, for example, we see that on several occasions he self-discharged.
Yes.
But there's no recording of what
whether
the
mental
discussion was
capacity
around that, was there?
Yes,
and whether
exactly,
there was any reason
exactly.
to do.
So even the hospital should be involved. I think everybody, it should be a multidisciplinary team involving all the people, including the social care, including the GP who is concerned, because who knows the long history of the patient. So it should not be taken as an isolated incident.
No, I think what I'm saying is, in some ways, what we have to be careful of is making sure the right person is the decision maker, but that doesn't mean they have to do it in isolation. They can take the views on board of others, particularly multidisciplinary teams, social care colleagues, etc.
Yes.
But also it's about recalling that the Mental Capacity Act is date, time and issue specific. So a decision around discharge from hospital might well be done by a medic, but some of the decisions around managing his care in the community, if he lacked capacity, might involve a district nurse or a
Yes.
diabetes specialist nurse or something like that. Or maybe in certain cases, in terms of commissioning a care package, that might involve social care colleagues. So it's about, although the Act forces us in a way to have a decision maker, because you can't have rule by committee, that doesn't mean to say we can't all share suggestions, information to help the decision maker make a fuller assessment. And I think one of the things that was quite sad in Michael's case was, you know, his daughter telling professionals he's not managing, he's not coping, and people not really listening to that. And there seemed to be a lot of situations in some of the cases I've been involved with where people struggle with deciding who the final decision maker is. On that note, I would like us to move on a little bit more around sort of the relevant conversations we need to have with people where we do have reason to question. As I say, I'm a type 1 diabetic myself, but no one need to question my capacity, might question my capability, but that's because I've had a lot of good, helpful support from staff to understand diabetes. Jane, can I bring you in this point to talk about some of the educational work you do with people to try and help them understand and what is the essential information they need to know?
Well, I think they do need to know at least the basics about diabetes. And as Dr. Blarney said, they need to know about what normal blood sugar is, what they're, what they want to achieve. And, things like diet, how diet can help, how activity levels can help. But also they need to, if they're on medication, they need to have a basic understanding of how it works. When to take it, things like that. So a lot of time and effort goes into that initial assessment with people, because that's the time when you're getting to know the person and getting to understand where they're coming from. What, you can pick up early cues about whether someone's taking information on board. And often if I feel that what I'm telling them is going over their heads, then I will kind of make it more simple, break it down, use information leaflets, pictures, very much trying to reach them where they're at, because it is important that they have some basic understanding, because they are the ones that are living with the diabetes all the time, and we're only there. They might just only see us once or twice, maybe 3 times in a year, so that they have to have at least that basic understanding. And if they don't, then that's where we need other agencies to come in and give them support, basically. So that initial assessment's really important, to assess what they do understand, what they need to know, and then adapt how you give that information to suit their needs, basically.
I think what you described very well there is making reasonable adjustments, really, depending on the individual as well, and not just relying on verbal information, but the benefit in using leaflets and diagrams and demonstration as well. I always remember the first time someone showed me how to fill a diabetic pen, and I was terrified I was going to get it wrong. And actually, you've done it so many times, it becomes simple. But the first time, I still try to hang on to that memory of the first time, felt terrifying. Yeah,
absolutely.
Thanks,
there's so much involved in the first time, because you might have someone who's scared of needles, you might have someone who's got preconceived ideas about insulin, and it can be very, very scary for them. So you do have to take your time and go through things. And we're really fortunate now, we do have a wealth of resources that we can share with people to help back things up. We've got videos that they can watch, we've got booklets by the individual, depending on what insulin we're starting, which will go through things bit by bit with them. So it is very useful to have these things.
One thing that I always hang on to as well, the biggest thing I learned is you don't give insulin for both states. If somebody's in hypo, because I had it in my head before I knew anything about diabetes, the treatment for diabetes was insulin. And it's amazing how many staff you even come across who still think, well, if somebody's in a hypo, give them some insulin, which is opposite, isn't it? And you get some funny looks as a diabetic when you're stuffing jelly babies in because your blood sugars have gone low. But, there's that social context to it. Trish, can I bring you in here as well? What I'm interested in is there's been some case law around, diabetes is a complex mix of decisions. It's not one straightforward decision. And I think sometimes I see people struggle because they don't know, is this, do we need to reassess capacity every single decision, which could be every single meal, every single injection, or is it in the round? There was a very famous case in Greenwich involving a judge was basically faced with a case where he was asked, is it lots of little decisions? Is it groups of small decisions, such as a group of decisions around what you eat and the impact that has on your blood sugar? Or is it one big overall decision about how you manage? Because they're all so intertwined. I mean, what's your experience in working with people? Do you feel it is better to see it as one overall management decision, if you like, or do you prefer to break things down?
In an ideal world, it'd be one decision and that would be quicker. But in reality, no, that's not the case. In reality, patients, and I think Jane will agree, that we're getting more and more patients refusing, in particular, blood glucose monitoring, and the community nurses can't administer insulin without the blood glucose reading beforehand. There's simple things that when I see the nurses in the team document patient has capacity to consent for treatment, it's a bugbear, because what are they consenting to? What is it they're actually consenting to? So I always say to them that you need to document what it is that you're doing with them. Do the patients, as Jane said, the questions they ask, do they know what medical condition they've got? Do they know how insulin works in their body? Do they understand, if they don't accept insulin today, what that means and what could potentially happen to them? But for me, it's about a shared thing, because with the capacity, like you said, about is it every single decision, I think that's what frightens community nurses, if I'm honest. They feel that they've got to do this full huge document that we've got for assessing capacity every single time. And it's not feasible or realistic to do that. So,
and I guess
the basics of capacity is you have to assume capacity unless you're given you can assess that there's not capacity. In Michael's case, for me, it would have been very beneficial to actually speak to Michael's daughter as an advocate for him, and to pursue that where we felt he was making unsafe decisions.
But I guess, in a sense, going back to what you said at the beginning there, you demonstrate beautifully how one decision does impact on the other. So in some ways, making them a separate isn't practical either, is it?
No, it's not.
To pick up on the recording, I mean, that was a key issue in Michael's case, wasn't it?
Yeah.
People said he had capacity, but hadn't actually recorded anything around the information they'd given him, the responses he's made to evidence one way or other, and almost a comment that there was no evidence he had capacity, when the assumption's the other way around. What about things like how would someone who had maybe executive dysfunction in their sort of decision-making skills, how might that impact carrying out an assessment on someone, even someone you're seeing several times like your staff would be?
Yeah, well, community nurses in Sutton Health and Care have 91 visits for insulin administration and diabetes management per day. Yeah. So there's a lot. So they would only consider capacity where there's a refusal. I would, that if someone's not refusing, they're assuming capacity. So I think. So I've lost. What was your question again?
And I guess I hear what you're saying. The volume of work is so massive. In some ways, that's where I think the beauty lies in that decision about macro decisions, because I think the biggest challenge for me is that we are trained to believe, and rightly so, the Mental Capacity Act is date, time, and issue specific, which takes us down that every choice, every day decision route. When actually, I think the best way is, particularly when you're working with people over a long period of time and having regular contact, is a more longitudinal assessment of their capacity, taking in information from other professionals, from family, as you said, to get a fuller, rounder picture, really. And I think sometimes in terms of executive function, people can appear to function very well, or at least they seem to understand what you're asking them. But telltale signs are often things like they then promise to do one thing and then don't. they seem to have very little recollection of having said, no, I'm not going to do that, I'm going to do this. So also sometimes I think you tend to find people where their executive dysfunction skills are impaired are keen to please. So sometimes they can look like they're understanding what you're telling them because they don't want to look like they're not, and they're trying to please you. So I think there's some traps in it, and I think that's why, for me, assessing over a period of time, testing whether somebody really can comprehend information, they have got the memory skills to be able to store, retrieve, and use that information. They can make judgments, for example, titration of their dosage. They can use planning around, I'm going on holiday, how much insulin am I going to need? Where am I going to get my repeat prescriptions if I move? I think all those kind of factors you can judge over an extended period of time that are very, very difficult to do in one-off. Are you going to have your insulin or not? I think you also hit for me on a danger as well, and that is assuming if someone is not refusing that they're consenting.
Yeah.
Acquiescence and consent can be different.
Mm-hmm.
I think for me that teaches us to at least think about capacity at the beginning when we're doing some of that, maybe that educational work Jane's talking about. And that highlights a beautiful reason for the two of you to chat about it, really. What did you find, Jane, when you were talking to him about the educational stuff? Dr. Jyoti, how was he when he was talking to you? Did he seem to remember the information we'd given him? That triangulation of the evidence can be really helpful and really supportive of each other, because you don't feel you're in isolation at that point.
And I think in general, the diabetes nurse specialists and community nurses do work really well together and communicate about complex patients. Let's not forget, majority of patients who are on diabetics on insulin are fairly straightforward. There's the odd few complex like Michael, and we do communicate quite well, don't we, Jane?
Yeah, we do. Yeah.
If
there's ever any, I think that's something that that does happen. We will, if we've got concerns on either side, we will contact each other and discuss it. And that goes across the board with my colleagues as well, and the other district nursing teams. I cover a particular area, but I think that also what I'm noticing is that now there is more working with other specialities. We're seeing a lot more. I'm working a lot more with learning disability nurses in the community, where there are more complex patients as well. So I think it's improving, and I think it's for patients like Michael. I think where they sort of go under the radar, that because they don't kind of fit, and there's this I suppose, I don't know, but I've come across that sort of thinking, well, people are allowed to make unwise decisions within the capacity, and that can be confusing for people and for staff, and it's trying to get it right, trying to get that balance right for patients.
Or be pedantic, they're allowed to make decisions others deem unwise.
Yes, no, that's very true. Absolutely.
You can tell me it's unwise, right? But it doesn't feel like it. I think you've led me beautifully into the last point we were going to discuss, which is about how we work together. And yourself and Trish and Dr. Jyoti have spoken a lot around how health communication. And bring you in here, Sarah, from a social care perspective. Do you think that you're also involved in some of that support work and understanding what someone's health needs are and shaping a care plan around them?
Absolutely. I mean, I would like to start my response by explaining that with the client that I continue to support, who is quite similar to Michael in lots of ways. Once his GP had kindly agreed to undertake the capacity assessment and deemed him to be making unwise decisions, that was then a jumping off point to really strive to work in collaboration with the patient client himself, and just present the facts to him. There was one incident prior to my involvement which was of particularly distressing to hear about, which was him being pinned down by the London Fire Brigade to obtain a blood sugar reading from him. And I just put it to him, you don't I want to avoid that ever happening to you again. And it was on that basis, like I said, in the notion of collaborative working, that he actually agreed to a move of placement. He was in supported living to residential care, where his food was always provided for him. He never had enough money for food and was constantly, through his Dexcom, having a very low blood sugar reading. So I would start by saying working together has to involve the person, like I said, at the center of all these discussions.
Yeah.
And I would add some personal experience there as well. One of the things that I always found frustrating is the assumption that it is straightforward. You know, my blood sugars change if I'm stressed, they change if I'm poorly, they change if I'm busy, if I'm running behind and didn't get a chance to take my meds. It's an ongoing everyday struggle. And I think sometimes when people don't comply, it's because they have very chaotic and hectic lives. I mean, you know, for Michael, he was living in very difficult circumstances. He didn't have a lot of informal support. And it's very difficult to be very routinized, I guess, and disciplined. If you're not sure what your next meal is going to be, and as in the case of the guy you're describing, it's very difficult then to plan your insulin regime. And it's sort of recognizing that diabetes itself is a complex situation that varies for every person, but services aren't always in a position that you can adapt that quickly. So it is, for me, it is vital that we share information. Little things like at no point in my journey was I ever asked about my mental health or whether it had any impact. And I would have probably, you know, stubbornly denied it at the beginning. But I think looking back, being 40 when I was diagnosed, it was a massive culture shock, a massive culture shock. And what I wonder sometimes is whether people have time in their busy schedules to be saying, Michael, you know, you're not managing your diabetes. Do you want to talk? What else is going on for you at the minute? What would be helpful for you? There's almost a focus on the medical task or the social care task we're there for. And as you say it yourself, Trish, through 91 visits to get through, you see where that pressure comes from. But I've often thought on some of my diabetes appointments, but you don't understand. It's frustrating today because, or this is going on. And, you know, put myself in Michael's shoes, which I'm not. It feels like he was making lots of decisions that were considered unwise, but there's not a lot of detail there about why.
That was what I was just going to say. That has to be the most important thing. Why is he refusing? What is the reason for refusal? Because it could be something as simple. I'm just going to use another patient as an example. This patient constantly refused blood sugars to the point where she got violent with the nurses when they tried. And they were making decisions. She hadn't got capacity. They were making decisions in her best interest to do this, and it was as simple as having something like a Libra device fitted, so she didn't have to have that. She didn't like the finger prick, you know. Very simple little thing adjustment, you know.
And I think that's a really good way of, you know, sort of highlighting that there's a small thing but can have a big meaning to one person and less of a meaning to others. And that's really fitting with the ethos of the Mental Capacity Act about individuals making individual choices in that sense. Well, I think we've covered some really good ground there. Is there anything anyone thinks important to add that we've not previously discussed? Dr. Balani, anything you feel?
No, I think we've covered all the aspects,
Jane, anything you'd like to add?
I think that's it,
Trish? Sarath, last but not least, sir.
Just to emphasize a point that I've already made, which is to consider the patient as central to any discussions that's being had that directly impacts him or her.
I'm going to end on a personal quest. One of the things I always do when I'm considering mental capacity is think, what would I want? What would I want someone to do to help me at that point? Which is difficult when people are busy in busy services, and, you know, would I want to be ringing 6 professionals to tell them all the same thing, or would I want people to share information? Are there some things I wouldn't want them to share with others? You know, it's always a good way, I think, to keep yourself focused by thinking, if that was me or my loved one, what would I want for them?
Can I just agree with Sarah? I think ultimately one of the questions that was asked at the start of this is who is the decision maker? Ultimately, the person themselves have to be the decision maker, and it's up to us as professionals to make sure they have the information to make informed choices and decisions.
And where they can't, there's nothing wrong in having a discussion as a group and supporting each other and sharing our experiences, and ultimately the person who's going to do the deed making the decision. So if that's a support worker preparing a meal, they need to have the relevant information in their care plan. If that's the consultant prescribing which kind of insulin the person needs to take, they need the daily information from the blood sugar readings that the care staff are getting. We all are dependent on each other really to work as a team to support people. I think that's been really productive, guys, and I think we're about bang on time. So thank you very much for your contributions.
Thank you.
Thank you.
Thank you.
Stephen.